Welcome everyone to this video on drugs for coagulation disorders. We'll be exploring the medications used to manage conditions involving blood clotting, both when it's excessive and when it's insufficient. This is a critical area of pharmacology for nurses and medical students, as these drugs are frequently used in a variety of clinical settings. Coagulation can mean life or death, literally. Without proper clotting, a paper cut could become life-threatening. But with too much clotting, a minor injury can lead to a stroke or pulmonary embolism. So, medications that affect this process are among the most powerful and delicate tools we use in medicine. Let's begin by reviewing the normal process of hemostasis, which is the body's way of stopping bleeding. This involves several key steps, starting with vessel spasm to reduce blood flow. Platelets then adhere to the injury site, forming a plug. Finally, fibrin strands create a mesh that strengthens the plug, leading to clot formation. The liver and vitamin K are essential for producing many of these clotting factors. Think of hemostasis like building a brick wall. The platelets are the bricks, the fibrin is the cement. Without both, you can't seal the leak. And without vitamin K, you're missing the ingredients for the cement. Quick fact, the liver produces most clotting factors, and vitamin K is its secret weapon. That's why liver disease and malnutrition can cause easy bruising or bleeding. Now let's discuss fibrinolysis, the process of breaking down blood clots. This is crucial for restoring normal circulation after an injury has healed. Fibrinolysis is initiated by the release of tissue plasminogen activator, or TPA. TPA converts plasminogen to plasmin, which then digests the fibrin strands, dissolving the clot. This process is carefully regulated to ensure that only unwanted clots are removed. Fibrinolysis is like the cleanup crew after a construction project. Once the clot has done its job, we need to remove it so that blood flow returns to normal. TPA is like sending in a bulldozer to gently knock down the scaffold. Thromboembolic disorders occur when blood clots, either thrombi or emboli, obstruct blood flow. These clots can form in arteries or veins, leading to serious complications. Examples include pulmonary embolism, or PE, and deep vein thrombosis, or DVT. Drug therapy with coagulation modifiers is often necessary to manage these conditions and prevent further complications. A thrombus is a clot that stays put. An embolus is a clot that travels, and where it stops, it blocks blood flow. Think of it like a traffic jam. A thrombus is a blockage in your driveway. An embolus, it's gridlock in the highway, often with life-threatening consequences. Many patients after surgery are started on anticoagulants to prevent DVTs. Why? Because lying in bed slows circulation and makes clots more likely. Drugs that modify coagulation can be broadly classified into three categories. First, we have anticoagulants, like heparin and warfarin, which prevent clot formation. Second, we have thrombolytics, such as Alteplase and streptokinase, which dissolve existing clots. Finally, we have hemostatics, like Aminocaproic acid, which promote clot formation. Each class has a distinct mechanism of action and specific clinical applications. Here's a simple breakdown. Anticoagulants equal prevent clots. Antiplatelets equal make platelets slippery. Thrombolytics equal dissolve clots. Hemostatics equal stop bleeding. Accurate laboratory testing is essential for managing patients on coagulation-modifying drugs. Tests like activated clotting time, or ACT, and activated partial thromboplastin time, or APTT, help us monitor the effectiveness of anticoagulants. Understanding the normal values and the significance of abnormal results is crucial for safe and effective patient care. Think of lab tests like your GPS while driving these medications. Without them, you're driving blind. For example, APTT monitors heparin PT, INR, monitors warfarin. Continuing our discussion of lab tests, platelet count, prothrombin time or PT, and thrombin time are also important. These tests provide valuable information about a patient's clotting ability and can help us identify potential bleeding or clotting risks. Remember, careful monitoring is key to preventing adverse events. Platelets are the frontline soldiers. If the count is low, even with perfect clotting factors, you're still at risk. And always look at the whole picture. Low platelets plus high INR, that's a bleeding disaster waiting to happen. Nursing tip. If your patient is bruising easily or bleeding gums, check their platelet count, especially if they're on multiple anticoagulants. Let's focus on anticoagulants, specifically heparin and warfarin. Heparin acts rapidly to inhibit clotting factors, while warfarin has a slower onset of action. Heparin is typically administered intravenously or subcutaneously, while warfarin is given orally. Monitoring parameters and having antidotes readily available are essential for managing potential complications. Heparin, fast, short-term, IV or SQ warfarin, slow, long-term, PO only. Heparin's antidote, protamine sulfate. Warfarin's, vitamin K. Can you think of a reason why we might use both heparin and warfarin at the same time when starting therapy? Drug interactions are a significant concern when using anticoagulants. Many medications, including other anticoagulants, antiplatelet agents, and NSAIDs, can increase the risk of bleeding. Certain herbal supplements, such as green tea, ginger, and ginkgo, can also interact with anticoagulants. Always obtain a thorough medication history to identify potential interactions. Even herbal teas and vitamins can interfere. Always ask patients about over-the-counter meds and supplements. Nursing tip. If your patient is on warfarin and drinks green smoothies daily, you must educate them about consistent vitamin K intake. Heparin is a commonly used anticoagulant with a variety of clinical applications. It's important to be aware of its actions and uses, as well as its potential adverse effects and contraindications. The black box warning regarding the risk of epidural or spinal hematomas is particularly important to remember. That black box warning means you should never give heparin to someone getting a spinal or epidural unless the provider clears it. The risk? A hematoma can compress the spinal cord, leading to paralysis. Red flag alert. Watch for signs of spinal cord pressure, numbness, tingling, weakness in the legs. Report immediately. Warfarin, also known as Coumadin, is another widely used anticoagulant. It's crucial to understand its mechanism of action, adverse effects, and interactions. The black box warning about the risk of major or fatal bleeding highlights the importance of careful monitoring and patient education. Warfarin is like walking a tightrope. It can be life-saving when balanced correctly, but a slight tilt can lead to dangerous bleeding. That's why consistent monitoring and education are key. Foods like leafy greens and drugs like antibiotics can throw off the balance. Clopidogrel, or Plavix, is an antiplatelet drug that prevents clot formation by inhibiting platelet aggregation. It's important to be aware of the potential for variable effectiveness depending on metabolic activation. Also, be mindful of the risk of bleeding when used with certain herbal supplements. Clopidogrel works like anti-glue for platelets, but the catch? Some people's bodies don't activate the drug effectively, so they take it, but it doesn't work. Always assess if the patient is seeing benefit or if genetic testing is needed. Alteplase or Activase is a thrombolytic drug used to dissolve existing blood clots. It's essential to differentiate between hemorrhagic and ischemic stroke before administering thrombolytics. Increased bleeding risk is a significant concern when Alteplase is used with anticoagulants, antiplatelet agents, or NSAIDs. This is the clot buster, the emergency squad that demolishes blockages. But giving it to the wrong patient, like one with a brain bleed, can be fatal. That's why a CT scan is always done before giving it during a stroke code. As nurses, we play a critical role in the safe and effective use of anticoagulants, antiplatelets, and thrombolytics. Assessing for bleeding is paramount, requiring frequent vital signs monitoring. Remember that warfarin is contraindicated in pregnancy, while heparin and low molecular weight heparin can be used. Bleeding isn't always obvious. Check gums, urine, and stool. Don't forget neurochecks. Pregnant patients, warfarin crosses the placenta. Heparin is the safer choice. Now, let's shift our focus to drugs that promote clot formation, specifically hemostatics. Aminocaproic acid, or Amicar, is a prototype hemostatic drug that inhibits fibrinolysis. Be aware of its actions, uses, adverse effects, and contraindications. Other hemostatic drugs, such as thrombin and tranexamic acid, are also available. Hemostatics are used when we need to preserve a clot, like post-surgery or with hemophilia. Think of them like the sealant you spray on a leaky pipe to stop it from reopening. Nurses have several key responsibilities when administering hemostatics. Monitoring for clotting is essential, as is careful administration and monitoring of the IV site. Teach patients to report any symptoms of clotting or bleeding, and advise them against taking aspirin. V sites should be checked often, not just for bleeding, but also for swelling or warmth, signs of a clot. Teach back is key. Ask your patient, what would you do if your leg starts to swell? Let's test your knowledge with a question. A patient with DVT is receiving a heparin infusion and will be started on warfarin soon. Which lab test should the nurse monitor to evaluate the therapeutic effect of heparin? Is it prothrombin time, PT, international normalized ratio, INR, activated partial prothromboplastin time, APTT, or platelet count, APTT is the go-to for heparin? You're basically checking the brakes. If it's too long, the brakes are locking up, bleeding. Too short, the brakes have failed, clotting. The correct answer is activated partial thromboplastin time, or APTT. While a patient is receiving heparin, the APTT should be 1.5 to 2 times the patient's baseline, or 60 to 80 seconds. An APTT greater than 80 seconds indicates a risk of spontaneous bleeding, while an APTT less than 60 seconds suggests a risk of clot formation. Think of APTT like a Goldilocks range, not too short, not too long. It must be just right to prevent clots without causing bleeds. Always double-check the latest result before hanging the next bag. Here's another question. A patient with atrial fibrillation is being treated with warfarin. Which lab test should the nurse monitor to evaluate the therapeutic effect of warfarin? Is it prothrombin time, PT, international normalized ratio, INR, activated partial prothromboplastin time, APTT, or platelet count, PT-INR is like the warfarin dashboard. It tells you how thin the blood is. INR is the standardized score across labs, so everyone is speaking the same safety language. The correct answer is International Normalized Ratio, or INR. PT is expressed as INR and is used to monitor warfarin levels. The INR should remain between 2 and 3 for patients on warfarin to prevent clot formation. Remember that INR is monitored more frequently when a patient starts anticoagulant therapy or when the dose is changed. Let's consider a clinical scenario. A nurse is caring for a client receiving warfarin therapy following an ischemic stroke. The client's PT INR was completed at 7 a.m. with an INR reading of 4.0. What is the nurse's first priority? The nurse's first priority is to assess the client for bleeding and notify the physician of the lab results and current warfarin dose. The INR should be between 2.0 and 3.0 for a patient on warfarin following a stroke. An increased dose of Coumadin would increase the risk of bleeding. Remember, look beyond the numbers. Dark stools, altered mental status, bruising, or hematuria might be your first signs that the INR isn't just high, it's dangerous.